Welcome everyone to the call. This is Valerie Cape at CMQCC. Thank you for joining us today to learn a little bit more about quantifying blood loss. I want to go over a few administrative things before we start. If you have a question, please feel free to type it into the chat box and we'll address it. If it comes up that it's critical to go over it right during the presentation, we'll do it then. Otherwise, we'll have them at the end. If you have signed up and you want to get a CE for this class, webinar, and you called in as a user with a number after your name, please send me a chat in the chat box because I don't know that I can identify you to make sure you get your CE for the for attending today. So I see that I have a user number 2, 4, 8, and 11, and 17. I'm not sure I can identify who you are. So if you think that's who you called in, you didn't put a name in or something when you came on the call, it would be great if you could send me a chat. I want to introduce our speaker today. Her name is Jennifer McNulty. She is a physician at Long Beach Memorial Children's Hospital and has been very involved in the hemorrhage collaboratives and has a really great presentation for you today to talk about how to quantify blood loss and make it easy for you to accomplish this task. So with that, Jennifer, I'm going to make you the presenter. And then you can proceed with your slides.
Okay, can everybody hear me? This is Jennifer McNulty.
Yes, we can hear you.
Okay, great. So, well, I'm very pleased to be with you here today, and I am very pleased to see the number of people who are interested in this topic who have called in. My goal today is really very simple, and that is to give you some information about the journey that we had at our facility in instituting, and I will say successfully instituting QCL, and why that journey has really made us here more convinced than ever that this is a very important part of our efforts to reduce maternal mortality and morbidity. And I want to give you sort of really the nuts and bolts of how we did it and how we do it, and hope it is simple enough that it could be tackled at your facility. So those are my goals. And again, I'd be very happy to take questions before, during, or certainly in the days after this presentation if people have an interest in emailing, calling me. If I can ask people to please remember to mute your lines. Thank you.
Excuse me, we just had a bunch of people come on in a group in a room, and we're hearing a lot of feedback. If you could mute your line right away when you come on, that would be really great. It's *6 or #6. Thank you. Go ahead, Jennifer.
Okay. We're not here enough. Okay, well, I'm going to try to go forward. So really our job come to work every day is to not only
So Jennifer, let's just wait for a minute.
Okay.
Let's just take a break. We had a group that has joined in the call. We have a group that's joined in the call, and we can hear a lot of the feedback that you're there in a group together. We want to wait till everybody's muted before we go forward. So if you are in the meeting, we ask everyone in the meeting, whether you're in a group or at your desk, to make sure that your line is muted. I believe with WebEx it's either #6 or *6, or you can press the mute button on your phone, but do not put us on hold. We do not want to hear elevator music. And when I stop talking, I'm hearing a lot of feedback in the background. That tells me someone is not muted yet. So we'd like you to make sure you mute your line. Okay, a little bit of feedback still. Someone still isn't on mute. Okay, thanks. It sounds all quiet. Go ahead, Jennifer.
Okay. So, one of our missions as providers of health care to patients is to not only do our job every day, but hopefully to improve the work that we do and how we do it. And I love this quote from Maya Angelou. that I'm sure many of you heard. I did then what I knew how to do, but now that I know better, I do better. And really, that is a good summary of, I think, what our journey has been for QBL. So I just want to give you some background here. And, you know, maternal deaths in California, this is a paper that is hot off the presses. Dr. Elliott Main, the director of the California Maternal Quality Care Collaborative, just published this paper in the April journal of the Green Journal, and looked into the question, among many things, as to which of our deaths in California were felt to be preventable and what percentage of cases. And as you can see from this slide, if you go down to the third category, obstetric hemorrhage, you will see that of these cases, 70% were adjudicated to have been largely preventable with a good to strong chance, and another 25% to have been preventable with some chances or having averted that maternal mortality. And hemorrhage had the highest percentage of the cases which were deemed to have been strongly likely to have been preventable. And why were these cases preventable? So if you look at the third column here, obstetric hemorrhage, you can see that healthcare provider factors with a delayed response to clinical warning signs, that's the blue bar, were prevalent in a high percentage of these cases, and it looks like the units is off the axis, but it was in excess of 80% of cases, there were delayed responses to clinical warning signs. The second most common category for obstetric hemorrhage deaths was ineffective care. And many of those cases, I think, were situations where the thing was done over and over again, but the care wasn't moved on to the next level. So this is a case composite that some of you may have seen before that comes out of the work from the maternal mortality pregnancy reviews in California. An example of a woman who had a post-stage infection, as they often are, it was prolonged. She had a vacuum-assisted delivery, immediately was noted to have hemorrhage. Had with uterotonics, had a curettage, seemed to get better with those measures. The physician leaves the hospital, but is called back about half an hour later because the patient is continuing to bleed. And at that point, please note she is hypotensive. And we know that women who are laying in their bed in a supine position and hypotensive have generally already lost half of their blood volume. Steps were repeated, no escalation of what the care plan is. There was delay in getting blood, and she did not get her first unit until over 2 hours after the hemorrhage started. Before that time, she coded, and she ultimately died of multi-organ failure. Now,
Jennifer, if I can interrupt, there's a call-in user number 2 and call-in user number 25. If you could mute your lines, and also Carolyn Sanders, if you could mute your lines, that would be great. It's #6 or *6.
I'm on the phone. I'm on the computer.
You have to mute your mic on your computer.
Okay.
Or the little mic that's on the WebEx. Thank you.
Can you hear? Can you see?
No, we
I
can
muted it. No, you can't hear her.
No, that's for a speaker. One is the
Sorry, Jennifer.
Right here.
I can see who's not muted on the as the host, and so that I just want to interrupt so if we could get a few more of the lines closed off. That'd be great.
No problem.
Go ahead.
Okay. So now what if you take that scenario and you think about it in this way? What if we use QBL kind of as an additional vital sign, if you will? And this is actually a case that I was involved in 7 days ago when I was covering labor and delivery. And I thought it was illustrative of some of that thought. So this was a G1P0 who suffered arrestive dilation at 9 centimeters and underwent an uncomplicated C-section by her primary obstetrician. The woman was moderately obese with a BMI of 35. During the routine report out of the QBL in the operating room by the OR nurse, the number obtained was 750 cc's. And that number was reported as the physician was completing the subcutaneous skin closure. A dressing was placed by the staff. At that point, the physician left the operating room. But prior to the patient being transferred to PACU, as our routine, the maternal fundus was expressed, and the staff noted that there was a lot more blood than was typical, and they quantified that additional blood loss for 300, and I'm rounding the number, but it was like 302 or something. The nurse, although not alarmed by the total blood loss of 11 or 1,050 at that point, because that would not have been an unusual number for us, understood that 300 cc's with uterine expression was not typical. And she notified the physician who, with that information, opted not to leave the hospital. And sure enough, 20 minutes later, the postoperative recovery room nurse called the physician for a large amount of vaginal bleeding, at which point I was called to assist. When I arrived, the patient was noted to have significant lower uterine segment atony, although her fundus was firm. She was treated with uterotonics and Thackeray balloon, and that seemed to be effective. Meanwhile, the PACU team did a QBL on the large lake that the patient was sitting under at that point, in that point, and quantified an additional 1,250 cc's. So that means that this patient is now down over 2 liters. And remarkably, her heart rate was 90, and her blood pressure was normal for her, 110/60. So this lady had no abnormalities in her vital signs, and yet because we had quantified blood loss, we knew she had lost probably about half of her blood volume, or was approaching that. And as a result, we immediately ordered 4 units of cells and immediately had those delivered up to the recovery room for transfusion, and we were hopeful that we had resolved the problem. However, unfortunately, additional bleeding occurred despite the measures that had been utilized, and the decision was to go back to the operating room. By that point, she now was tachycardic and was hovering on the verge of hypotension, but she was already getting 2 units of blood, and we had 2 more units ready to give her as we got ready to operate on her again. And we had already requested FF when we made the transfer back to the OR. In the OR, she had an additional 1,100 cc's vaginally as we were getting ready to operate on her. And as a result of that, we went ahead and activated our massive transfusion protocol. And within 10 minutes, we had another 6 units of uncrossed PAC cells in the OR ready to give to her. So again, in this situation, you can see that the fact that we really truly did have a quantified blood loss was very helpful to us in prompting us to order blood products much quicker than we would have otherwise if we had only gone by vital signs. So quantification of blood loss has become a standardized recommendation from the CMQCC. It was part of our original hemorrhage guideline recommendations for all births, and it was re-examined this past year and reaffirmed for the new updated guidelines just released this last month. It is also an A1 standard recommendation for all births, and in 2013 it was one of 7 safety objectives put forth by the National Maternal Health Initiative. So there's plenty of folks who believe that this is important, but I know from experience and from having talked to lots and lots of people across the country, this is an area where there has been, I think, we've been maybe slow to adopt because it seems complicated, and in addition, there has been a thought of, well, how much of a difference is this really going to make? It seems like a lot of extra work. And I'm hoping that I can convince you otherwise during this presentation. So as for any changes that we want in the world, certainly in the healthcare system, we need to make it easy to do the right thing. We need to make it easy to do what it is that we want folks to do. And we need to make sure that the staff asked to do this has the right tools. First of all, you need some buy-in, building that burning platform. Why does this matter? It needs to be education. What kind of culture do we have here? What are the expectations?
You'll be able to view physician profiles so you can decide which doctor is right for you. Sharp accepts almost all health insurance. Visit sharp.com/doctor today. Thank you for calling Sharp. Your call is important to us. Please stay on the line and someone will be with you in a moment.
Can you tell who that is?
Yeah.
Okay.
I'll send him a message.
The New Beginnings Boutique and Gift Shop at Sharp Mary Birch is a full-service breastfeeding resource center staffed with certified lactation educators to provide breastfeeding support and guidance to new and expectant parents. There you'll find breast pumps for sale.
Jennifer, I'm going to step off the line and see if I can actually reach this person by phone. I'm just going to put my phone on mute.
The boutique has new hours and is now open Monday through Friday from 9 a.m. to 6 p.m. and Saturday and Sunday, 9 a.m. to 5 p.m. There's a tool for Sharp Restali and Sharp Hospital patients and most Sharp Community Medical Group patients who want to manage their health care and the care of their loved ones from their computer, tablet, or smartphone. It's called Follow My Health. You can schedule and cancel appointments, send and receive messages.
Excellent. Okay, so I'm going to go on. So some things are very important as well, just in terms of the logistics. So if we want people to quantify blood loss using weight, we need to have a scale in every room. In our facility, we started off with having a rolling baby scale that went from room to room to room, and that created hurdles. So ultimately, we put a scale in every room. You need to have calculators that have the ability to automatically subtract out dry weights. It's not reasonable to expect people to scribble on pieces of paper and do these calculations. At least it wouldn't be reasonable for me personally. So we need to make things easy. So the process that we have worked out is that in our facility, for every single birth, we begin QBL immediately after delivery of the infant, and we continue an ongoing assessment until the bleeding is stable, and that usually includes a total time period of about 2 hours postpartum. We kind of divide that into the acute phase, and that consists of the QBL at the time of the vaginal delivery, and I'll go through the nuts and bolts of this in a minute, or the intraoperative QBL for the C-section, which in the example I gave you a moment ago was that initial 700 QBL plus the 300 from the expression of the fundus. So that would be the intra-op QBL. Then we shift to the postpartum phase, which in our facility is for vaginal birth, it's from delivery to the time of transfer to the postpartum room, or the time from the recovery room prior to transfer to the postpartum room if it's a C-section. And the total QBL part of our SBAR to our postpartum nursing staff from either our PACU nurse or our labor and delivery nurse. So that's part of our standard SBAR communication. And we know over and over and over again that as healthcare providers, we are poor at estimation of blood loss with large volumes. And we consistently underestimate large volume blood loss, and those are the ones that really matter. And as I already mentioned, the data from California, detailed review of the cases of maternal death showed that significant blood loss was underestimated in all of those cases. Studies have shown that we can get better with training in estimation of blood loss, and we did a lot of work at our facility around that. But we found that those gains in knowledge are lost partially over time, and that even though we statistically can get better, that we still remain inadequate at estimation of large volumes. And this was not related to the experience of the provider, both in studies that we did at our facility as well as others reported in the literature. And we know that denial leads to delay, and that's what we're trying to avoid. Importantly, and we really found this to be true, if we didn't make the standard workflow in all cases, then we certainly didn't know how to do it when we needed to do it. And when you talk about a facility that has large numbers of providers, large numbers of staff, unless all of those folks are doing this routinely as a no big deal, this is just how we do it here, then when there is a true emergency like the case I just described, people don't know how to do it. And it was amazing to me in that case last week to see the staff step up and do the quantification of blood loss. They knew how to do it. They didn't have to think twice about it. It's just what we do here. And it was really incredibly gratifying to see that happen. Sorry, I'm having trouble advancing the slides here. There we go. So important in our culture and in our teaching of our staff was that the goal is not a perfect, precise number. And I think that was a mental hurdle that a lot of folks had, because when we were asking, particularly for our nursing staff, to give a quantified blood loss, immediately the perception was, well, I have to get this number right. There is a true with a capital T number that I have to get it right, and I have this additional responsibility, and I don't want to mess it up. And we all know that QBL is not a perfect number either. Inaccuracies will still persist, and that's just the way it is. There's going to be contamination with amniotic fluid in the canister we'll talk about there. There's going to be some urine in the underbuttock straight. There may be clots in the underbuttock straight that don't get down to the measured meniscus. You know, fill in the blank. But our goal is not to have a perfect number. Our goal is to have a more accurate number than with EBL. So again, it's also important to be able to better communicate among team members, and for a nurse to be able to call the physician and say she's having more bleeding than expected and it was 300 cc's. She can give the physician a precise number. You know, if we get a phone call from a nurse saying she feels hot, we say, well, what's her temperature? Not just that she feels warm. So the goal is to be more precise in our communication with one another as well. So some of the nuts and bolts about how we did it at our facility. So we started thinking about this back in 2009 to 2010 when we participated in the first hemorrhage collaborative as a team. And at that time, we started encouraging, you know, attending lectures. We all know the drawback of lectures. It's not a really great way to disseminate knowledge because it's very passive. But we started with that. We also started doing skill labs for our nurses, which were required, and encouraged physicians to do so as well. And those labs were primarily focused on visual estimations. So we would have a station where there would be a large spill of blood on the floor. There would be, you know, clots. There would be all sorts of examples using some of our, you know, pads and things that we use in patient care to try to improve visual estimation. There was a didactic part that went with that. There was a pre, there was a post-test. We talked about how to do better visual estimation. We put some changes in our electronic medical record to reflect that we were doing that. And we began improving documentation of blood loss in our deliveries. But the staff was confused about some of the different methods we were using, whether we were doing underbuttock drape measurements, whether we were doing visual estimation. And at the same time, we did a study here that found that although we got better between the pre and post-test visual estimation of blood loss, that we were still pretty poor at large volumes. And so we finally decided that directly measuring QBL was really the way we wanted to go, and that was going to be the only way we did it in our units. So in 2011, we began a much more aggressive campaign in our units regarding the definitions and methods for QBL. We put information up on our electronic message boards. We had talking points in our daily nursing huddles. We had discussion at all staff meetings. We disseminated information in the unit newsletter. And we removed in our electronic medical record a category of percent saturation as the way that we measured blood loss. And so that the only options in our electronic medical record would be direct measure and weight of bloody items, that all QBL was going to be using those two methodologies. We also started, one of our nurses did a What's in the Pouch campaign to educate and encourage participation with respect to vaginal birth. And we started tracking and posting how well we were doing at documenting QBL on our units. And we had improvements over that time. So in terms of nuts and bolts, the underbuttock drape, I think, was critical. Before the original collaborative, there was no commercially available drape available in the United States, and we were able to work with the vendor we were using to modify an existing drape and add printed markings and calibrations. And a fenestration was inserted as well to prevent items from falling into the calibrated portion of the drape. So vaginal birth, we have divided our QBL into a two-step process, which is what we do 95% of the time. And so for vaginal birth, part 1 is the QBL immediately after delivery. So the physician or other care provider finishes at the perineum, and the question is, what's in the pouch? And the pouch is lifted up, and you look at the meniscus, and you look at the calibrations, and you record that. Now, if the patient schwanned just prior to delivery, or maybe there was polyhydramnios, or maybe there was an amnioinfusion going on, and there was a large amount of fluid noted at the delivery, then that amount we note before delivery of the placenta, and we subtract it from the final volume. But the vast majority of our cases don't have enough fluid at the time of delivery to really justify worrying about that. And so we only do that when it's indicated, but most of our cases we just measure the final meniscus at the end. So that is the first number that gets recorded in our EMR. And then part 2 is the QBL at the completion of the recovery. So in a normal woman who's not having any abnormal bleeding, then we don't do QBL throughout that entire 2-hour postpartum period. But what happens is the patient has a standardized pack placed on her perineum and under her, and I'll show you what that looks like in a minute. So every patient gets that same pack of dry weight items, and at the end of the 2-hour recovery period before the patient goes out to the floor, that entire bundle is weighed, and there's an automatic calculator in our system that subtracts the dry amount. And then that is recorded as the recovery QBL, so that's our part 2. And only rarely is there a part 3. So maybe there is an extensive vaginal laceration that requires lots of, we use something we call baby lap sponges. So they're half-size sponges that have a radio-opaque tag on them. And so maybe the physician used a ton of those at the time of delivery. Maybe he used 10 of those. Maybe the physician noted that there was a lot of blood on the floor, and so she's going to ask the nurses to weigh that. So we have dry weights of all additional potential items posted on the scale in each delivery room so that those items can be accounted for if necessary. But we really emphasize that truly 95% of the time it's a 1-2-step process, and that's it. So the nurses know how to do step 3, and obviously those are the ones where it's going to be potentially most important. But in the teaching process, we really just wanted to emphasize part 1 and part 2 because that's what it is most of the time. So this is just an image of the underbuttocks drape. The one challenge for those of you who are used to using these is that the very apex of this cone is pretty long. It's way down low so that the calibrations can measure the blood volume very accurately. But this bottom portion of the drape tends to hang down and be obscured kind of in the kick bucket under the bed. So you do have to kind of lift this drape up in order to see the blood in the bottom. And for most vaginal deliveries, it's a very, small amount typically. And this is what it looks like, obviously filled or partially filled. And this is just an image of the scales that we have in our delivery room. So you'll notice this is a little tiny scale because most of the time we're not weighing large items. We're weighing a bunch of, baby laps, and I'll show you the standard perineal pack that we weigh. So all the items are put together in mass in a red bag, and they're weighed on this little scale. You will notice back here in the picture, the scale is bolted to the wall. These are small scales, and they had a tendency to walk away from the rooms. And then you'll also see back here on the mirror is an index card with the dry weights of items that might be necessary. We do have wheeled separate baby scales that we could use in the delivery room if we had a large volume spill that needed to be accounted for. But for most deliveries, these little scales work quite well. And I can get you the item numbers on those for people who might be interested. So this is a picture of the standardized pack that we place on the perineum for women after a vaginal delivery. So it includes this white chuck. It includes a large peach peri pad. It includes this cold pack. This is the wrapper that the cold pack comes in in, and there is some absorption. I don't know how much can be absorbed in this, but there's definitely some absorptive properties. So these 3 items have a single dry weight, and every patient gets one of these, and those are bundled up in that red bag and weighed at the end of the recovery period and added to the final QBL. So now I'm going to talk about cesarean section, and this is the one that for us was certainly much more intimidating. And in fact, we did not tackle QBL until at C-section until we had participated in the two collaboratives in the state of California. We had done vaginal QBL for quite a period of time, and we had a sister hospital that does about 3,000 deliveries a year who had already started doing QBL at C-section, and we kind of hung back until we saw what lessons they had learned. One of the things that we took advantage of from that hospital is that one of their anesthesiologists developed a little Excel calculator that automatically subtracted dry weights, and we took that calculator as a system and we took it to our build team, because we use Epic here, and they were able to embed it in our electronic medical record, and I'll show you a picture of that in a minute. And that was key to our success. We also assembled all the stakeholders in advance with representation from the women's operating room, which is a totally separate department from our labor and delivery, as well as the OB anesthesia department chairperson, labor and delivery nursing leadership, including educators, and OB physician champions. And just to give you some background, at least in terms of the challenges that we were dealing with here, and every center has its own challenges, of course, but we are a private, urban, nonprofit hospital. We are affiliated with the university training program, so we do have in-house 24/7 residents, fellows, and MFM staff. But we do more than 6,000 deliveries a year at our center, approximately a third of which are cesarean. And one of our staffing challenges and education challenges, as I mentioned, is that our OR department was staffed separately at the time from the women's labor and delivery department, and cesareans were staffed by a mix of women's labor and delivery staff and women's operating room staff who operated under different leadership structures. So there were some challenges, political challenges in that setting that we had to address. So when we started doing this, we, really tried to stick to the small test of change principle. We really wanted to test out the processes to how we were going to do this, and we weren't sure when we started exactly how that was going to be. We learned some things in the collaboratives from some other hospitals in California who were starting this ahead of us, and we took notes from them. We also tweaked the process several times as we went along, and I want to share some of those tweaks with you to save you maybe some time. We did some demonstration cases during very selected cesarean sections over several months. Initially, as one of the physician champions, those were my scheduled C-sections, where I had staff in the OR that I knew them well. They were willing to be my guinea pigs and work with me to see how we could make this work. And we also did some selected resident scheduled cases, again with staff who were willing to sort of step up to the plate and see if we could make this work. We also developed some one-on-one mentoring between our labor and delivery nurses and our operating room staff who were identified as being champions. Remember, our labor and delivery staff had been doing QBL at vaginal birth for some time now, and we wanted them to help mentor some of our OR staff who were not as familiar with why we felt this was important. We really emphasize, as with vaginal birth, that 95% or more of the time this was a two-step process. We also learned that it was not reasonable to expect every physician to take the lead in this process or even to buy in at all. My experience is if you expect everybody unanimously to say, hey, great, let's do this, you're going to be only disappointed. We really made this primarily a staff responsibility. But over time, even the sort of naysayer physicians have accepted this as just a standard work process because it was going to happen with or without them. As I mentioned, it's critical to make it easy. We made sure we use a baby scale in every C-section room, so we don't have to go out in the hallway and look for one. We have the calculator with the built-in dry weights in our EMR. You could also use an Excel program on your desktop and your computers. And we've learned that we only need those dry weight cards for fewer than 5% of cases, because those dry weight cards, when we first developed them, were very intimidating for folks to look at. It's like, oh my God, I'm supposed to subtract all of these things. And it was extremely, I think, intimidating for folks. But it turns out you don't need that most of the time for most cases. Timing was really important. We learned that as well. We need to be able to report that number out so the entire team knows the number before the patient leaves the operating room. And that's important because that was, you know, standardly a communication that happened between anesthesiology and the OB surgeon. So we didn't want that number being entered after the patient's already left the room, and so has the rest of the team. So in order to accomplish that, what we learned is that we were able to do the two-part QBL well before the dressing is even applied to the patient. And we wanted that because we don't want the staff to be bogged down with doing this when they are needed for the final wound dressing and moving the patient out of the operating room, because people were very worried about, is this going to affect operating room turnover time, which we all know is a pressure point for OR staff. And again, we emphasize that this is a quick process. 95% of the time it literally takes less than 2 minutes to do, and I'm going to show you that here. So what is our process? So part one is the liquid blood, just like at vaginal birth. So our process is we deliver the infant. We make an attempt to suction amniotic fluid in the drapes. Some physicians will buy more into that than others. At that time, the scrub tech, the person who scrubbed in, signals to the circulator to change the suction tubing to the second canister before the placenta is delivered. And I will tell you that we don't even do that step in cases that have come out of labor and delivery who are arrest of dilation or arrest of descent who have been ruptured. Most of them don't have sufficient amniotic fluid that it's worth subtracting. So in those cases, we do not change our suction tubing canister at all. In the cases that are scheduled, or they're twins, or there's polyhydramnios, or there's obviously large amounts of fluid, we will change the suction tubing. So again, the process is the scrub tech asks the circulator to change the canister tubing because the scrub tech is in a position to see what's happening up on the table. So that's it. And then the second suction canister is the one from which we record the QBL at the end of the case. And I'll tell you when we do that in just a second. So the second part is the bloody sponges. And our OR process in the main OR, the C-section ORs, is that the sponge bags are filled through the case by the circulator who places a sponge in each container. We use sponge container bags that hold 5 sponges. So those are tossed off during the field by the scrub techs during the case, and they're periodically hung up by the circulator. And at the end of the case, and by the end of the case I mean when the the skin closure, the subcutaneous tissue closure is going on, that's when the entire bundle of the sponges in their hanging bags is rolled up just like a carpet, and we take that whole roll over to the baby scale and we weigh that. And that total weight is entered into the EMR, and the number of sponges and sponge bags that are weighed are entered into the EMR, and the calculator calculates out the QBL from that. And that is all that we do for 95% of cases, and that total QBL is reported to the team before the abdominal dressing is being applied. We rarely need part 3. As in the case I started this morning talking about, if we express the fundus and there's a large amount of blood, then we weigh that. Maybe it's in the kidney basin, maybe it's from the chuck underneath the patient. Sometimes we'll have cases where there's a big spill on the floor, and so we might mop that up with a sheet, and we'll weigh the sheet and subtract the sheet weight. But again, that's a very small minority of cases, and that's when we use those laminated cards. So some of the things that we learned were that changing culture can be hard. habits that are ingrained that we've all been doing for decades are very hard to change, even though they're not optimal. Again, switching from EBL to QBL was an adjustment. There was this self-imposed pressure to get it right. We all accepted that EBL was an estimate, but suddenly when you said, well, we're quantifying it, it made people feel pressure to get the true with a capital T number. Previously, it was handled by the anesthesiologist predominantly. So, you know, although most of our anesthesiologists were happy to have this become not their responsibility anymore, there were a few who were resistant to that. So those were things that we had to deal with, and we had lots of individual conversations between champions and the various team members and individual staff members who were concerned about some of these issues. One of the things that we did observe that, particularly for C-section, that when we had a QBL that was higher than our EBL would have been, that most of the time that was blood that was in the sponges. And we realized that there was a lot more blood in our usual C-section sponges than we ever really accounted for. We also found in the past we had not been hanging those sponges up in violation of our own operating room policy, and it sort of reaffirmed for us the visual cue, the importance of the visual cue when people walk into the operating room, particularly if there is a hemorrhage, of seeing those bloody sponges very visually as a cue to what is going on in that room. We also learned, by the way, that we were inconsistently putting sponges in the correct places. So some people were putting 10 in a bag, some were putting 5 in a bag, which is what we were supposed to be doing. And so, again, we weren't following our own policy, and we had to get consistent with that. And now, let me talk about irrigation, because this is something that comes up a lot, and we learned some lessons about that. What we learned is that it was much better to exclude irrigation and to do the QBL canister prior to using the irrigation at all, because what happens is when you pour irrigation into an incision, let's say you pour it into the gutters, that you don't generally completely suction it out into the canister. And we found that in the majority of our uncomplicated C-sections, the canister QBL was often a very small amount. Sometimes it was only 150, 200, 250 cc's. So if your true blood in the canister is, let's say, 200 cc's, and you irrigate with a liter of fluid, that liter then you're going to subtract from your canister volume at the end. But you might only aspirate out 700 cc's of irrigation back into the canister. So then you're going to subtract 700, which is what you got 700 into your canister plus 200 of your blood. Now you've got 900, but you're going to subtract 1,000 cc's of irrigation, which is what your scrub tech said you poured in. So now you're going to get a negative number. So we discovered quickly that this was not really optimal. So what we do now is like what we did before, which is when the physician's getting ready to irrigate, we look at what's in the canister at that time. And for most physicians, they don't irrigate until the uterine incision is closed and you're getting ready to close. And that's commonly when irrigation is done. And that's when most of your blood loss is going to go into your canister and be done. So that's usually an appropriate time to sort of close out that canister and go ahead and enter that number in your calculator. And we've also encouraged physicians to consider omitting irrigating entirely, that may not even be necessary from an evidence-based standpoint. But if you are going to irrigate, you want to close out the QBL in the canister before throwing that irrigation in there. So this is in our operating room. You can see right here, this is a case where we did change the suction tubing. It was a scheduled case. Canister number 1 over here on the left was mostly amniotic fluid. Canister number 2 was the canister that we're going to do our QBL from. And then over on the right-hand side is the hanging sponge bags, and there's 5 sponges per bag. And these sponge bags are unhooked from their containers en masse and rolled up like a big giant carpet and laid in the baby scale right here. And so in this particular example on the scale, the total weight of this whole bundle was 786 grams. And that is the number that was recorded in the calculator. In addition, we recorded that there were 2 sponge bags used, And I think in this example, there were maybe 10 sponges that were weighed. And again, we do this after we've closed the fascia in most cases, because the sort of the amount of blood and the sponges that you're going to have from closing the subcutaneous tissue is just not worth waiting for. It's not worth accounting for. So this is the example of the calculator that's in our electronic medical record, and hopefully everybody can see this here. So right here was the canister volume of 200 cc's, and this was the total weight in our example of the lapped sponges and sleeves. So there, in the example in this calculator, there was 1 sleeve used and 5 bloody laps that were weighed. And then down here, this number, blood loss calculated, is 376 minus the dry weight of 1 sleeve and 5 dry laps plus the 200 cc's in the canister. So we ended up with 451 cc's as our QBL, done automatically for us. So once we did the demonstration cases, and we worked on this for a couple of months, and we had some, individual counseling and with our champions, we started with our scheduled cases. So all of our operating room cases that were scheduled, elective cases, we did QBL on all of those cases. And then over that time period, which was 2 months, we solicited feedback from the staff. What was working, what wasn't working, what were the challenges, what physicians were giving you pushback, and this required some conversations, between our champion anesthesiologists and some of their partners. I certainly had some conversations with some individual physicians, some of whom were less enthusiastic or were inappropriate with nursing colleagues, unfortunately. And when direct conversations were had, people were willing to sort of back down. They were willing to agree that, yes, all of us share the same goal of providing better patient care, and also acknowledging physicians who said, well, there's still inaccuracies in this, and we said, yes, absolutely. We agree there's still inaccuracies, but data would suggest that this is better than the old way of doing things. So we did that after a couple of months, and then after 2 months, then we rolled this out to all cases, including those coming out of labor and delivery. So we hung these posters 4 months in advance of starting this because we wanted complete transparency. We wanted people to know that this is coming. This is the way we're going to be doing this. And so this just emphasized the 2-step process that we were doing for C-sections and what it was going to look like. So we wanted people to, every time they turned around, walked into a bathroom, sat at a computer, they were going to see this poster. So in summary, for C-sections, we really wanted to emphasize that this was a 2-step quick process, and I'm not exaggerating when I say that 95% of the time this takes staff less than 2 minutes. You need a calculator. You need to make it easy. You need to build it into your EMR if you can, or have at least an Excel spreadsheet on your desktop. We started with the cases of just a few physician champions. We did small tests of change. We wanted to see how it would work. We tweaked it. We wanted transparency. We wanted everybody to know this is coming, like it or not, this is happening, and give people lots of advance notice. Again, our process for us, we did scheduled cases first, and then we added unscheduled cases when we'd had a little bit more experience. And this is just to give you a sense of how it's going. Let's see, hopefully you guys can see that. So we started this in earnest in late 2011, and the orange line in the graph is our success rate at documenting blood loss after a vaginal birth in the postpartum period. Let's see, I hope everybody can see this. The blue line is vaginal QBL at the time of vaginal birth, the light blue line, and then the dark blue line, and we're at essentially 100% now, is QBL intraoperatively at C-section, and then the yellow line is C-section recovery room QBL. So we have really made this a standard part of our process now. So in summary, the lessons that we learned is that we needed to make this part of all of our deliveries. We needed to have sufficient resources, scales, education, a calculator. We needed to make this part of nursing and staff routine workflow, that we couldn't rely really on physicians to be the people driving this, unfortunately. You know, to us, this is no different than doing the sponge count at vaginal delivery or a sponge count at a C-section delivery. It's just this culture of what we do. We have the 2 key steps at vaginal birth, the blood and the underbuttock drape, and then the blood at the end of the recovery period. And at C-section, we have the 2 key steps, the blood in the suction canister and the blood in the bloody sponges. And those are the 2 steps that we use. And with that, I think those are the end of my slides. So I would be very happy to take any questions. And I can look at the chat box and see what's on that too. Valerie, do you want to add anything?
Yes, thank you, Jennifer. That was a great presentation. Thank you so much. I want to just tell everyone that the meeting has been recorded, and it will be available as a webinar that you can look at again if you need to, you know, review some of the things that Jennifer talked about. If you signed on to the meeting and you didn't provide your name at the beginning, even though you've registered for the call, we may not be able to identify you to give you a CU if you are requesting that. So if there's any question about you getting your CU, please email Julie Vasher, and her email is jvasher@stanford.edu. And I don't see any questions in the chat box. Does anyone have a question that they would like to ask Jennifer before we sign off on the call?
I actually put a question in there. This is Gail from Riverside. Are we going to get a copy of the slide deck?
Yes.
Yes, you are. You can get a copy of the slide deck. We'll make that available.
Also, I'll just make a note that the poster that I showed is available in the updated version of the hemorrhage toolkit, as well as the screenshot of the calculator that we use, as well as an example of an Excel spreadsheet that people could use. So that's in the state hemorrhage toolkit for this year.
Yeah, those are in the version 2.0 that just came out in March. The calculator example and the poster. They're both in the new toolkit.
Yeah.
Okay. So there's a question about Neptune for fluid disposal. Any suggestions for those who use Neptune?
You know what? I am not familiar with what Neptune is. Someone educate me.
We're not being able to hear who is ever talking.
This is Kelly Phillipson. I'm from Kaiser, but we use a disposable. The Neptune actually takes the fluid, so you don't have the risk of splash and things, and then it hooks to something to rinse it out, so you're not pouring fluid. So we don't have the canisters any longer that you switch out.
So how do you? I'm sorry because I'm not familiar. So are you able to visually see the blood that's in it, or how do you know how much is in it normally?
Well, you can see it measures up the side. You can see how much is in there.
Okay. So there's calibration, but you can't exclude. You can't do it in a two-part process. What you're saying?
Correct.
No. You know what? I don't know. I'd like to think on that a bit, but I don't really know the system, so I don't have an obvious solution to that off the top of my head. But perhaps I could look into it a little bit, and maybe you might have a thought. I apologize. I'm not familiar with that system, so I'd have to think about it a little bit.
Okay, great. Thank you.
Yeah, it's be worth thinking about, though, because I'm sure there are other folks who are using that, and I've not heard of it before.
So there was a question about the name of the vendor where you can purchase the pouches.
I think all of the major vendors, I think we have Medline, Cardinal has it as well. The product numbers are not toolkits, and we can certainly get those and post it. Sorry?
So there is a question that we had a little trouble hearing the response. We're getting a lot of feedback on one of the lines. If you're not asking a question, could you please keep your line muted? That would be great. So the vendors would be Cardinal and Medline. Is that what you said, Jennifer?
Yeah, I believe both have them.
Okay.
Valerie?
Yes?
Dr. Stewart from Doctors Medical Center wanted to make a comment about what we were speaking about.
We have a similar system to the Neptune. It's called Door Knock, and it does print out, or it shows you an estimate, but it's very inaccurate under a liter. So ever since we've had these instituted, I've felt that there's no way to visualize. I mean, you could switch off after the amniotic fluid, but visually it's almost impossible. There's no place to see the blood. And I do think they're less accurate at lower volumes. They were really intended for like orthopedic cases with a ton of irrigation as a disposal system. So I personally don't think without the return of canisters, that system would work here easily.
I mean, it may be something, and again, I don't know enough about it to comment on it in a very educated manner, but, you know, it may be something that as a system, if it is a significant barrier to doing this, then it may be something that in the obstetric arena that you say that this is just not the correct process for OB cases. In the case we have that, or we do something different than the trauma center does, and that's the way it needs to be. So that may be something to think about. I don't know.
Any other questions that you might have for Dr. McNulty?
I'm curious if anybody's on the call, if they'd be willing to share if anybody is currently doing QBL at the time of C-section. Is there anyone who would be willing to share that they are or they're in the process of doing it?
This is Aaliyah Shibi from Riverside. We are doing QBL. Can you guys hear me?
Yes, we can.
We are doing QBL at Riverside. However, the resistance that we're getting is that it's like, I think you brought up a great point that we're not getting accurate assessments. It's not that it's actually over more than we thought, it's under. Like we're getting a lot of 300 cc's, 400 cc's.
Yep.
And actually we're getting, it's much more and we know it. And
yeah.
What's going on is that they're changing the canister, you know, when the uterus finally clamps down, you know, you're switching it when the fluid comes out, the amniotic fluid, and that there's some blood in there when the uterus kind of clamps down. So inherently there's some blood loss with that. So what's going on is that the blood is there, the QBL is underestimated. It's less. So what the providers are like, okay, you know, it's not that accurate, so I think it's actually more like 700 or 800. So that's the feedback we're getting. So they're like, QBL is great when there's a hemorrhage, but is it really needed during routine cases? So that's kind of the questions that we're getting at our facility. I don't know if you've had any of those comments.
Are you, if I may ask, are you weighing and doing the QBL from the sponges?
They are. They
okay.
are. They are doing the sponges too, and they are switching the canister after the amniotic fluid is sectioned.
Okay.
They are switching the canister at that time.
Because our experience has been that most of our QBLs from C-section, the canister volume is sometimes it's only 100 or 150 or 200. It's a pretty small volume. We find that we have several hundred in the sponges, that's where most of our blood loss is from. So the canister volume is usually very tiny. And it would surprise me if with a C-section you're only getting 100 or so out of your sponges. So that's my only comment.
Yeah, I mean, it's only in those routine ones. Like the failure progress, there are definitely more. It's in a routine, like, and they're not that much blood loss. But you know that, you know, when the uterus clamps down, you know there's more blood. Like when there's some blood loss with that as the uterus clamps down. I mean, after the baby's delivered, there was not that much afterwards. That's just the comments that we're getting. But otherwise, I mean, the QBL has done well. And
one of the things that we're going to try to report from our facility, because we've got 2 years worth of data now, and we've been on electronic medical records since 2009, where we've been documenting, you know, prior to that we were documenting EBL. And we're going to try to just look at our distribution, like what is our bell curve of actual QBLs for C-section and vaginal delivery, where clinically the provider didn't believe there was a hemorrhage and the clinical course would support that. What does that bell-shaped curve look like? Because we have had, I think our experience is that the bell is much, much broader than we would have suspected before. And we do see vaginal deliveries and C-sections with very, very low blood loss. And that's probably accurate lots of times. I think the bell curve is a lot bigger than we would have said it was before. Yeah.
Okay.
So maybe in the near future we'll have some data to share with folks on that, because I've been
Okay, great.
Yeah.
Okay, great. Thank you.
Sure. Thank you.
I know we are at about 1:30. I'd like to try to be mindful of everyone's time. Are there any more quick questions?
Just a quick reply to the previous answer question. At Kaiser, Walnut Creek, we're already doing QBL on all C-sections and also on vaginal births too.
Great.
Yeah.
Great, thank you.
And I agree. Yeah, the last caller said sometimes we get a very low QBL, but we should also look under the chest, under the patient when we move the patient, because there's a lot of blood there too.
Yeah, sometimes. Okay. Thank you.
Well, thank you, everyone. I want to just do a little bit of housekeeping as we end the call. We will have the slides available for you, and the call was recorded, so the presentation will be available as I think it will come out as an MP4 maybe, but we will have it available. We'll send the link out to everyone. I wanted to remind you that on May 12th, we will be having another webinar like this one where we will be talking to Holly Mason, who's the president of the California Blood Bank Association, and she will be presenting about some blood bank issues and things that will help you in getting your blood and understanding more about how that process works. So with that being said, if there's any other questions or you have issues about getting your CEs, you can contact Julie or myself. And thank you, Dr. McNulty, again for your time today, and thank you for everyone on the call, and we'll talk to you soon. Thank you.
One other thing, Lori. Oh.
Yes?
I was going to say that we might consider putting out a listserv. I think there could be some good conversation around the topic, and people might be interested in having, a listserv with a topic on this.
Okay, we'll do that. Yeah. Thank you so much, Jennifer.
Thank you. Bye.
Bye.
No, but you need to watch. When your patient falls into the high risk group, that she has less than 700. When the patient is in the postpartum. That's like what are we going to do? No, that's older. They still this. So I really, because we know patients. We know patients really have no patients. So, this other I don't have any older. I just don't know one. This like there is similar. I don't have to all right. Now, and you don't. I don't know. Like you don't know. Like because later, yeah, because all these data content, I really don't know. This QBL is new. Whatever their mortality data I mean, we are keeping things the way of because we don't have isolated drawdown. But there is no research that shows after you do QBL, the comparison of your immediate reaction is mortality. What is the...
You know what? When a patient is hemorrhage, actually there's no difference if you do a QBL or you do a FBL. Because it's already bleeding. You know your patient is bleeding.
You're actually
right. You need to act. Let's go. You need to act right away.
Yeah, until they stop bleeding. If you
right.
Bleeding, you just
right.
Right.
So I see your point that it has no difference. Why we have to do so complicated? so many of these things.
To me, if you want to make your quality care, you have to simplify every procedure, not to add more. And it's just, if it was medical, it's okay. You can
or research.
Yeah.
So for us, actually, I think that all high risk patients not
oh,
Big sections maybe when I think yeah, it should be on top. It should be on top of the right.
Enter your attendee ID number.
Right? But when you guys cooperate,
I don't express the patient. You might express your own patient, that's why I don't. And so I just, as a nurse, yeah, I'm not a
no, but they do express with them when they're treating the patient.
I know. We don't, that's not part of the QPL.
Before they get on to the you're right, that's probably not.
I just think it doesn't take the one you have to stick around. Yeah.
I practice it,
yeah.
So I don't do when I take off the break and I walk out.
No, I know. I have to. Well, I'm telling you, I know they don't do it because I get to QBLs before I leave the room. The patient's still getting her dressing on.
Make sure that it's expressed as
yeah, I mean, I know I can do that individually, but what I'm saying is that I think it's probably because you're stick around, you do the expressing.
Yeah,
you know, but a lot of people don't stick around, leave the room. And they're calculating that QBL before they even see the patient. Do we want to be more accurate with a role model? Yeah. When you're on the unit, I mean, personally, I'm just ready to get out of here quickly and keep it moving, so it takes so long to stick around. Turn the patient in. Well, you have to do that clinical check. Do you take them to the way? Well, they take them.
And I put up a leg and then I got there.
Well, no, but if you want to be really accurate, yeah,
do I have blood and if it's open, we say it.
Yeah, or just have to be on.
I don't think
well, wait, what they do is that
worry about them not eating. That's a significant amount. You know, they usually get, you know, probably anywhere from.
I mean, yeah, one of my kids. I know better.